control. We are not still able to address the underlying mechanism of action. And so from my side, I'm just going to be more clear only with the basics which I'm going to do. And the future therapies, like there are more drugs in the pipeline, I'm just going to highlight it. Like my therapy is like something which should help everyone to manage in their day-to-day clinical scenario. So this is my preview, and I'll start with an introduction. Antithyroid drugs, radioactive iodine ablation, thyroidectomy, which is the most definitive treatment option, and then your advances and conclusion. So Graves' disease, we all knew, this is an autoimmune condition where we do have circulating autoantibodies, that is the thyroid stimulating immunoglobulin, which goes and blocks the TSH receptors in the thyroid, in the eye, in the skin. So these are the major three organs, and we do have its action in the other tissues, but mostly we have hyperthyroidism, thyroid eye disease, and acrophagy. And how do we evaluate? Like basically by thyroid function test, TSH receptor antibody, ultrasound thyroid, and iodine 123 scan. So this is how we try to diagnose Graves' disease, differentiate it from its common thing of thyroiditis like subacute thyroiditis. And once we arrive at Graves' disease, like what are the treatment options available as of now, and how are we going to be addressing this in the future? So this is the main thing. So this all started with 1825. Only in 1825, this disease, that is Graves' disease and Graves' ophthalmopathy, was described by Robert Graves. And during those days, there is not much of a treatment for Graves' disease. Bloodletting, a crude phenomenon like which was actually there for most other diseases, has been there, was one of the major treatment here. And people were giving iodine-rich seaweeds and sedatives to control the agitation. So this is how it started. But something started to change when in 1909, when Robert Kocher, so he discovered the principles of thyroidectomy, and thyroidectomy emerged as a major treatment option for Graves' disease. So initially it was only thyroidectomy, no drugs, no radioactive iodine ablation. And then one day in 1920s, like people started to decode the role of iodine in thyroid hormone synthesis, then they started giving iodine. And then somewhere in 1923s, we did have thionamide drugs. And 1940s, radioactive iodine ablation became the most common modality to treat Graves' disease. I think since then, we do not have a much change in the shift of the thyroid hyperthyroidism treatment. We still address with this one of the three major treatment options, only the orders are being changed. So now treatment of Graves' disease, antithyroid drugs still remain as the first and the foremost treatment in Graves' disease. So if you look at antithyroid drugs, so drugs interfering with thyroid synthesis and action, so this is the thyroid hormone. Yes. So first we have how iodine goes into the thyroid, and then iodine gets oxidized, and then we do have synthesis of thyroglobulin, then coupling happens, that is T3 and T4, and then they get released in the blood. So this is the major step in thyroid hormone synthesis. And we look at thionamides, that is propylthiouracil and the methimazole, like carbamazole, like whatever we have, they interfere with the peroxidase enzyme, they interfere with the thyroglobulin synthesis, and they block the conversion, especially propylthiouracil, they block the conversion from T4 to T3. And we have iodide, so iodine is essential for thyroid hormone synthesis. Iodide is something which interferes with thyroglobulin synthesis, and it releases the, it blocks the release of T3 from T4. And we do have beta blockers which still release, which inhibits the conversion of T4 to T3 in the periphery, and it also blocks the action of thyroid hormones in its receptor. So we do have major things, thionamides, iodides, and beta blockers in this thing. So if you look at this case, like I put something to have a clinical perspective. So this is a 23-year-old female with typical symptoms of weight loss, palpitations, heat intolerance, and excessive sweating for 3 months, with neck swelling for the past 1 month, and then examination, her eye examination is normal, no proptosis. Like eye examination in a Graves' disease patient is very, very important because it helps us to decide the treatment option. and the clinical activity score, like which we usually do for a patient, and whether there's a presence of goiter or not, what is the pulse rate, and she had tachycardia, system examination was normal, and ultrasound didn't have any nodules. So this has to be done at the first visit to see whether the patient has nodules or not. So USG had only thyroiditis. So if you look at the thyroid function test, clearly FT4, FT3 was high and TSH was suppressed. Usually it's better to go by an ultra-sensitive third generation assay. So that is very important, and the TSH receptor antibody, which helps us in differentiating it from the initial phase of thyroiditis and Graves' disease. So TSH receptor antibody was clearly, it was positive 5.15. So with this, when the Graves' disease is confirmed, so how do we go about this? So as I said, methimazole or carbimazole, it remains as the first choice of drug for any Graves' disease patient, and propylthiouracil usually we reserve it for special circumstances, especially the first trimester of pregnancy, because this can be a teratogenic. We do have reports of choanal atresia, gastrointestinal system disorders, and so many effects. So we usually reserve it for the first trimester of pregnancy and thyroid storm. So except this, the FDA has warned in 2009 to not to start propylthiouracil in any patients, except that if they do not tolerate the initial drugs, when they have minor side effect, we can give. So this is the major difference in the mechanism of action. So it inhibits TPO, as I said, the thyroid peroxidase enzyme, and propylthiouracil is the one additional effect of preventing the conversion of T4 into T3. And half-life, this is the larger half-life, so we can dose it like once a day, but this needs frequent dosing because the half-life is like very less, and the onset of action, this is slightly faster, and propylthiouracil is slightly lesser, and we usually prefer this as the first line in most cases. And side effects are agranulocytosis, mild hepatotoxicity, and here we have agranulocytosis and severe hepatotoxicity. PTU has been addressed as one of the third most common drug causing liver transplant for drug-induced hepatotoxicity. You should be very, very careful with PTU use. And pregnancy, as I said, avoid methimazole in first trimester. Breastfeeding, yes, safe in low doses, like 20 milligram per day of nivomacrosol given after breastfeeding can be like considered as safe, and do not breastfeed after 4 hours of taking nivomacrosol. This is how we usually tell the patient. And the FDA black box warning for severe liver injury. And now coming to the dose, like how do we start methimazole in a patient? So this is a rough guideline from the ATA guidelines. What they say is when the T4 is like 1 to 1.5 times the upper limit of normal, so we can somewhere start between 5 to 10 milligram, and when it is 1.5 to 2 times the upper limit of normal, so we can give at 10 to 20 milligram, and when it is more than 2 to 3 times of normal, we can start somewhere between 30 to 40 milligram. And propylthiouracil, yes, the starting dose is somewhere between 50 to 150 TDS, and we maintain at 50 milligram TDS as the maintenance dose and gradually taper. And this is very important, the conversion dose, 6 milligram methimazole is equivalent to 10 milligram of carbimazole, which is equivalent to 100 milligram of propylthiouracil. Yes, and now monitoring, we monitor like once and 2 to 6 weeks initially, and we need both FT3 and FT4 because T4 normalizes rapidly when compared to T3, and TSH remains suppressed for months, and then we usually follow it up like once in 3 months. The total duration of therapy is 1 to 1.5 years, like which we must clearly explain the patient that they have to continue and not stop in between, and maybe we can continue for another 6 months if they do require a very low dose. So this is how we monitor. And this one I have to emphasize, a routine complete blood count is very much mandatory before we start ATDs and liver function test. Why this is important? Because the risk of agranulocytosis, like which will be coming up. So agranulocytosis is something where the absolute neutrophil count is less than 500. So any patient, we have to check the ANC, and normal ANC is between 1500 to 2000. So when it is less than that, we should be a bit cautious about giving them antithyroid drugs, and we can easily calculate total white blood cell count into percentage of neutrophils divided by 100, or we do have even a calculator available online. So now moving on to adverse effects. So cutaneous reactions are most common: pruritus, itching, hyperpigmentation, and rare effects are Stevens-Johnson syndrome. I did have 2 patients who developed very severe adverse reactions and now on radioactive iodine ablation. She's on follow-up. And agranulocytosis is something, when I said absolute neutrophil count is less than 500. So any patient patient, when we start antithyroid drugs, we have to be very clear in telling them, please watch out for fever, sore throat or pharyngitis, and instead of routinely monitoring CBC every visit, I think counseling the patient is very, very important, because these reactions can happen at any time. So even after 1 year it can happen. So we have to give this in written instructions. So that is what most guidelines say. And hepatotoxicity, we have to tell them to watch out for pruritus and low discoloration of urine. And so whatever it is, counseling is very important. And very rarely we do have ANCA-associated vasculitis, like which I have seen during my PG period, and autoimmune hypoglycemia, something which is a very rare side effect. So how do we manage this minor cutaneous reaction? Minor, it's only antihistamine therapy, continuing antithyroid drugs. When you have persistent symptomatic minor side effects, okay, counsel for radioactive adeno surgery. If they're not really, switch to the other antithyroid drug when that is not an option, and severe reaction, the drugs has to be discontinued. So the follow-up of the patient which I mentioned before, so she has been doing well, and then after 1.5 years, like the drugs was down titrated and it was stopped, and after 1.5 years, even in follow-up, she was normal actually. So this is a textbook type of picture. Like most patients do not have this expected results. Only rarely, like maybe 1 or 2 patients out of 10 might have, and sometimes they come with relapse. So the same patient after 1 year, she came with relapse of symptom, and then the FT4 and FT3 is high, TSH is suppressed, and the TRAB is again positive. The TRAB, like usually we do it before we stop the drug, it will actually give an idea whether the patient will go in for remission. For this patient, even though the TSH receptor antibody came down, she still had a relapse. So this is one predictive factor. We say the grade score, which actually helps us to see whether the patient at the time of diagnosis, whether they will have remission or not. So depending upon the age of the patient, free T4 levels and the TSH receptor antibody and the goiter size, we can actually grade them and then put a score. And the side, like actually we have, when the score is somewhere between 0 to 1, so they have only less chance of recurrence, and when the score is somewhere between 4 to 6, they have almost 68 to 70% chance of recurrence. So it will help us to have a rough estimate idea, and also it might help the patient to explain. So now, when she needed a definitive treatment, so the next option to be considered is nothing but the radioactive iodine ablation. So we give a radioactive iodine, which actually in a high dose, it causes DNA damage, it destroys, like which we usually do it in thyroid cancer, and in low doses, it actually interferes with the thyroid hormone synthesis, and it might produce hypothyroidism. So indications for radioactive iodine ablation is nothing but failed or relapsed after antithyroid drugs, adverse reactions, poor adherence, patient may not be able to take, and patient preference is like something which we have to consider. When they want a definitive therapy, I think we have to describe about this. Small goiter, mild to moderate ophthalmopathy, and women not planning for pregnancy soon, and the absolute contraindications, pregnancy, lactation, severe eye disease, and suspicions for presence of thyroid malignancy. That's why I said the ultrasound thyroid during the first visit is very, very important to rule out any nodules. And large goiter with compressive symptoms where we do not have penetration of the radioactive iodine much into the gland. So now, complete beta-adrenergic blockade is essential. Pre-treatment with MMIs to render them euthyroid, and MMI should be discontinued 2 to 3 days prior to radioactive iodine therapy, and pregnancy has to be ruled out, and HCG test has to be done on the previous day or on the morning when they take this radioactive iodine ablation, and this is the dose 10 to 15 MCI, which is a sufficient dose to achieve hypothyroidism. And follow-up, usually we start metronidazole after 3 to 7 days after radioactive iodine ablation, because once we give this, there is a damage, and then the antigens get released, and there is a triggering of hypothyroidism. So we have to give them metronidazole, monitor every 4 to 6 weeks, and see when they become hypothyroid, and then start them on levothyroxine. And with selected patient with minimal response, maybe we can consider therapy after 3 to 6 months of duration. And now, moving on to the next treatment modality, which is total thyroidectomy. So for example, if you look at this patient, a 32-year-old male, smoking is very, very important. History of smoking, because it helps us to decide the management of the definitive line of therapy with 6 months history of grave disease, grade 3 goiter and moderate thyroid eye disease, and which is actually inactive, and he is requiring high dose of carbimazole like 40 milligram even after 6 months of diagnosis. Like when someone comes like this, so we all do know that he is definitely not going to have a better response with antithyroid drugs, and we can start counseling them about the role of thyroidectomy or radioactive iodine ablation. But here, as I said, because he is a smoker and because he is having thyroid eye disease and grade 3 goiter, I think radioactive iodine ablation would not help him much, and it might even aggravate the underlying disease. So in such case, thyroidectomy is something which we have to consider. So what are the indications to consider thyroidectomy in a patient with Graves' disease? Yes, recurrent or persistent hyperthyroidism, and someone who is currently pregnant or nursing. So pregnant patient with thyrotoxic storm, we do not have any other option, or with someone with young children in the home where they are not able to adhere to the instructions after radioactive iodine therapy, this isolation and everything. Severe eye disease, simultaneous presence of a thyroid cancer nodule or some nodule which is being suspicious of thyroid cancer, and side effects of methimazole or PTU, and very significant enlargement causing compressive symptoms, and desire for rapid control. Yes, thyroidectomy is the same thing, complete beta-adrenergic blockade, achieve euthyroidism, potassium iodide, stop antithyroid drugs before that, and calcium and vitamin D has to be screened, and if the patient has large goiter and we expect an extensive dissection or something, so we can actually start with calcitriol to prevent permanent hypoparathyroidism. So someone who is allergic to antithyroid drugs, like how to render them euthyroid, it is like a full complete beta-adrenergic blockade to use propranolol and potassium iodide. So iodine solution, we can use potassium iodide or even Lugol solution. So 1 drop of Lugol solution contains 6 milligram of iodine, which is enough to settle the acute thyrotoxic effect. Glucocorticoids, cholestyramine, and very rarely, I forgot, lithium also can be used, because lithium also has antithyroid drugs. Like we did have reports of using lithium in a thyrotoxic storm patient to control hyperthyroidism. Those around 300 to 450 milligram of lithium also can be used. So this is like the thyroid storm, which I am just going to put in a detail. Like as I said, so propylthiouracil somewhere between 500 to 1000 milligram per oral load, and then 25 q 4th hourly, or methimazole is 40 milligram 4 to 6th hourly, and beta-adrenergic blockade, so propranolol and esmolol with a very high dose of 80 milligram even 4th hourly can be used, and then it's contraindicated if the patient is in cardiogenic shock. And corticosteroids, both hydrocortisone and dexamethasone can be used, and potassium iodide. So this is 5 drops per oral q 6th hourly, or Lugol solution 8 drops per oral q 6th hourly. So this is how we manage. This is just for a revisor. So now I'm moving on to the newer options. Like why didn't focus much on the newer concepts? Because they are still in the pipeline. We still do not have any drugs which is actually targeting the pathophysiology or something which is actually focusing at the Graves' disease per se. For eye disease, yeah, we do have lot of drugs, rituximab, teprotumab, and then even now, if these are the pipeline drugs, like if we see here, only the first one, the batoclimab is the only drug, even with the immunomodulating drug, which is being tried for Graves' disease. All of the drugs for thyroid eye disease, like whatever we have, it's only for thyroid eye disease, and even now we have only one drug for this. So I think as of now, we still have to be only with the older options like drugs, radioactive iodine ablation and thyroidectomy, and the future for Graves' disease, I still don't think it is like as much as promising with like other drugs, and so we do have a lot of guidelines and we do have biological therapies in the 21st century, but still nothing much have developed for the past even 100 years, like I should say. And then so with this I conclude, and thank you so much everyone for your patient listening. Thank you.